So, after more than a decade of no real changes in practice for untreated metastatic disease, over the last 2 years, we've seen that the addition of immune checkpoint blockade, PD-1 inhibitors to chemotherapy has changed practice for the first time. And the benefit does seem to be enriched in patients with higher PD-L1 expression, and certain approvals and NCCN recommendations are based on PD-L1 combined positivity score, which is assessed by a single site biopsy. But as is the case with oncogenic drivers or alterations, PD-L1 expression is also incredibly heterogeneous in this disease. And a biopsy of the primary tumor may have a different PD-L1 CPS compared to the liver biopsy. And patients who have an initial assessment at one institution that uses one assay may have a different score on a different institution, and dependent on the pathologist. So there's a lot of variability that comes to lead to this one single score that's supposed to have this output of a recommendation, right? What PD-L1, and so this was a pilot study looking at 10 patients who received a small molecule macrocyclic peptide called 18F-BMS-986229 that is PD-L1 targeting radiotracer. The idea being that after the injection of this tracer, they had comprehensive head-to-toe PET imaging to, at a single time point with a minimally invasive diagnostic tool, be able to evaluate PD-L1 expression across all disease sites. There are a couple of other pilot studies that have been published looking at other PD-L1 labeled radiotracers. Most of these are radio-labeled antibodies. One of the advantages of this tracer is that because it's a small molecule and not an antibody, the kinetics are much faster. So it allows for same-day injection. So the patients had the radiotracer injected, and then an hour later had PET imaging, as opposed to having to come in several days apart. This was also the first pilot study that evaluated PD-L1 PET imaging in gastroesophageal cancer of any kind. So that was really exciting. And what we saw is that this was a safety and feasibility study. We saw, number one, this was safe. There were no adverse events related to the tracer or the PET imaging. Number two, no patients had any delays in their treatment. Of course, the caveats of 10-patient cohort, we did see that it was concordant with radiologic and pathologic PD-L1 expression was concordant, because we had biopsies of all of the lesions and then radiographic assessments by expert nuclear radiologists looking at those. So there was concordance of this radiotracer with the pathologic evaluations, but it also highlighted the heterogeneity of PD-L1 expression. And then there were some signals that patients who had upfront PD-1 treatment who had avid lesions had a better outcome compared to those who didn't. But in terms of next steps, certainly need larger cohorts to validate these findings. And really the questions that it brings to mind are, how can we use this tool to better guide management and selection for patients getting PD-1 blockade? Is it going to be maximum avidity, change in avidity from pre to on treatment, change in FDG avidity by greater than 35% is associated with improved outcomes. So is it going to be something similar that we see with PD-L1 PET imaging? Or, perhaps thirdly, the homogeneity or heterogeneity of PD-L1 avidity. You can imagine two patients with liver and lymph node and lung lesions. One has all of their lesions are PD-L1 PET avid, and another just one is. You can imagine that perhaps the patient with more homogeneous PD-L1 expression on PD-L1 PET imaging might do better. Of course, there are limitations to PD-L1 expression itself predicting outcomes to checkpoint blockade, but this is at least a comprehensive, less invasive means of evaluating that.